Jim Jones.
Hey,
Welcome
hey,
to
hey.
Wednesday.
Welcome. Welcome. Great to see you.
Great to see you. I like the background. Jim
Yeah.
must be traveling because it could be like one of those, like, I don't know, New Jersey garages that opens, or it could be like a really nice fancy hotel, or it could be just a room. So,
Yeah. Calling from an undisclosed location.
yeah, I like it. I like it. Um, just a quick note. I saw one of our guests, Dave, just joined you at Clear IP. So I think all the
Yeah.
health tech folks are going into intellectual property.
Exactly. Exactly. Yeah, that was he
So
just put it out, put the post out, but that great call out. Yeah, he was one of our guests. So
that's
excited to have
right.
him. Clear IP is expanding. We're starting to commercialize right now. So all
Amazing.
all full throttle.
Rocket ship. Yeah, this is I actually looked. It's episode 172, and I also looked at least on YouTube. I didn't get a chance to look at all the other stuff, but
Yep.
we have almost 3,000 subscribers at this point, 60 short. So call to action if you're listening to this. Doesn't
Right.
take you long. Just hit that subscribe button, pass it on. Jim
Yep.
and I do this for fun, but the
Of
more of
course.
you watch, the better it gets. We promise.
Exactly. 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 Awesome. So who do we have today?
So I'm gonna let Peter in. So Peter and I, we were introduced by Olia, who I met through somebody out of Netherlands, way back when. And Peter was kind enough to respond. We were when I was in LA, and we had a wonderful lunch together in the sunshine, and just got to talking. And you know me, Jim, I kind of like, you got to be on the shot. So here he is, Jim,
Awesome.
Hey
Peter,
guys,
Jim.
thanks for
Welcome,
having me.
Peter.
Good to meet you. Well,
Yeah,
good to meet you.
yeah,
Good to see you. Yeah,
I'll see
it's
you
been a
again.
long
Nice to
day
meet you
here.
again.
Right.
Yeah,
You're always meeting new people. You're always meeting
Gotta.
love it.
for the shot, Peter.
Well, yeah, welcome to the shot. And for our millions of listeners and viewers, take us through, who's Peter? Where were you born? What do you do? Just would love to get to. I got to know you over lunch, but I
Yeah.
thought it was fascinating. But now
Oh,
our listeners' turn.
well, that's kind of you. It doesn't seem as exciting on my end, but I'm based in Southern California, outside of LA. I've been out here for about 25 years. I was originally born in Cleveland, so I was jinxed at birth at being a Browns fan,
Okay.
which has not been fun over the years. I finally gave them up a few years ago.
I was just gonna ask
Mistake.
if you,
You can
stuck with it.
no, I mean, it was like a piece of gum stuck to my shoe for most of my life. And finally, a
Mistake.
few years ago, when they
Mistake
did
by the
some,
lake, isn't it? Mistake by
yeah,
the.
they had some good years, and then they up and moved to in the '90s. They up and moved to Baltimore and became the Ravens and won the Super Bowl.
Right.
And then they were reborn, and they've been pretty unsuccessful ever since. But yeah, I lived there till I was 12 or 13, and then moved to Boston area and did the
Okay.
New England thing for a while. Went to school in Maine, and then went down
Okay.
to DC for medical school, and and then I married a woman who was from Calabasas, California, and she dragged me back
Okay.
here kicking and screaming.
Yeah. Punch up. You got to punch up sometimes, you know.
Yeah, yeah. No, I love it out here. I love it out here. We're blessed with amazing weather, and I'm an outdoorsy kind of guy, so I can just jump on my mountain bike or my road bike or go for a hike. I did that
And also
yesterday.
happy wife, happy life. So,
Yeah, there you
you
go.
know,
There you
that's
go.
it.
That's right.
So was it a big family that moved from Cleveland to
I had
Boston?
two sisters, so
Sisters,
5 of
okay.
us. Yeah,
Yeah.
yeah.
And were they
Pretty
all in
typical
medicine?
childhood. Nothing too exciting. I
Yeah.
was a soccer player, played soccer through college, and loved my science courses and didn't love my English courses and those kind of writing courses much. So I was always a
Okay.
science guy.
What position? What position were you on the field?
As forward.
Forward. Okay.
Yeah.
Got it.
Try to get that ball in the net.
I like it, Jim. I like it. We're diving into sports today. I think this is probably the first episode
I
in
think
172.
football is fascinating, the personality type, because you can kind of tell a lot by someone by their position on the field,
Yeah. Yeah.
But also,
No,
since this is a health tech show, I mean, movement is also medicine, right? So, we
Right.
weave
That's
weave
right.
that in. But
Awesome.
That's right. Yeah.
Okay, so
yeah.
you and where in life you met your wife at which point of your, so you graduated med school, you kind of give us a little bit from the med school onward.
Yeah, we met in orientation on day one, orientation
Okay.
from school. We were both in the same medical school class at George Washington.
Okay.
And we were, one of our key tasks on day one of orientation, talk about pressure, is you had to come up with a group of 6 that were going to be gross anatomy partners with one cadaver. And
Okay.
you had to have at least 2 of each gender in the group. So
Right.
there I was with 3 other guys. We had our 4-guy group. And
Yeah.
there were 4 women from Stanford who all knew each other, and they were forming a group. And so we
Right.
kind of looked at each other, and we certainly didn't want to be, the bad guy that left your new friends on day one.
Right.
But a little while later, I watched one of our 4 guys walk over and start chatting with the women, and then they're all hugging. And
Yeah.
it was clear that he had defected, and so I wasn't going to win. So I defected and joined the group. My wife was one of the 4.
Right. I like it.
Amazing.
Control the
Yeah,
odds.
yeah.
Put the odds in your favor.
That's right. That's right. We bonded over, over gross anatomy, which was not a very romantic place, I would say.
Amazing. Amazing.
Good start to the relationship.
Yeah,
And
there you go.
what did you practice once you
Yeah. So I thought I was going to be an academician. When I was in undergrad, my youngest sister, she was about 12. She had a pediatric cancer. And somehow I kind of fell in love with that specialty as this heroic sort of life-saving specialty that saves kids who are in, real tough shape. And so I pursued that. So I did a residency in pediatrics back in Cleveland where I still had family, and then fellowship at Stanford in Hem-Onc. And I did that the first year of Hem-Onc fellowship, which is the academic year. And then you hit the labs for the second and third year primarily.
Okay.
During that year, I had some second thoughts. It was a real draining specialty emotionally.
Right.
I wasn't really good at compartmentalizing away the tough stories and the sad stories.
Right.
Also, I got turned on at that moment. This was about 98. I got turned on to technology. We're 5 years into the internet being public. And I was in Silicon Valley where things were just exploding. And
Right.
so I kind of fell in love with technology and innovation and realized that I had a kind of an innovator gene, that I was spending more time. It looks like I'm
Yeah, we
sorry
lost you
about that.
for 10 seconds or so, but we can pick it back
So
up.
I
It's all good.
realized I had an innovation gene. During residency and fellowship, I certainly spent time learning my craft, but I spent almost as much time trying to figure out why healthcare was so broken and
Right.
trying to diagnose and fix the problems with our healthcare system. And
Right.
so I realized there's real opportunity to leverage those two, to combine technology as well as kind of innovating in healthcare. And I did practice for a while. I practiced general pediatrics from 99 till 2012 full time. And
Okay.
then that's in and around 2012 was where I really started making that transition.
Okay. So it's a long
I even
time.
started really earlier, even all the way back 2006 when the first iPhone came out. I wrote an app
No.
for the iPhone. I wrote an app for the early iPhone and Android phone called
Okay.
Pocket Pediatrician. It was triage and advice right in your pocket.
Amazing.
And,
So we got a real medical geek over here. I didn't realize that. That's amazing. Okay.
and then I
Was
moved
it
on
called-
to symptom
called
checker,
Was it called Pocket Pediatrician?
Pocket Pediatrician. Yeah.
Had
And
a
I-
good time.
So that was fun. It was a good learning experience. I learned how to wireframe and a little bit
Right.
about coding. I wasn't a coder. I had some coders code it out for me, but it was a good learning experience. And then I moved on to more deeper symptom checker content. And so I
Okay.
realized that by sketching it out, that if you took the common pediatric conditions within about 6 to 10 questions, you can usually figure out what the most reasonable next step is.
Right.
And
Right.
had a lot of fun with that, learned about branching chain logic and how to build that kind of content out. and then my first foray into real health tech, I came on as a consultant with a colleague of mine who had a company called Specialists on Call. You may have heard of Specialists on Call. Their primary use case traditionally has been telestroke. And so I started working with them on building out some new models of primary care. And, that was an eye-opening experience. That was a whole new world. This notion that you could interact with somebody from a distance. Back then it was really about point point-to-point care.
Right.
So it was Schoenberg machines, Cisco machines. But it really worked well for that use case. And then ultimately we found, if that keeps happening, I could just turn off my video. I think I'm just having a slow upload for some reason. But I realized that
it's all good. We're also on YouTube and people want to see the faces.
There we go.
It's all
good.
And
I realized that telehealth, point-to-point works for certain use cases like telestroke. It's a wonderful use case. You can save brain and save lives. But I realized the future of telemedicine was really going to be about interacting on usual consumer-grade devices. And that led me very nicely to Amwell, where that is exactly what Amwell was doing, or it was American Well at the time.
That's right. That's right.
Yeah. And so American Well was interacting by tiny little flash video screens and supporting video-based telehealth visits, which was really a novel concept. I mean, the main competitor at that time was Teladoc. And really those two are still in competition to this day, but Teladoc was doing most of their care by phone, and we really committed at Amwell that a video visit is a more robust visit. You can do more observational, you can interact more.
I do remember, first of all, I looked it up, which is kind of fascinating, right? Like, I don't know, to me, Amwell, like, I don't know, if I would have gotten woken up in the middle of the night, I would have said like a decade old, just like not thinking. It's kind of like it's 1982 and then it's already, I looked it up, 2006. So Roy and Ido, right? I mean, the two brothers. Right. And I still remember, I don't know, Jim, if you remember at Health 2.0, it's like, especially Roy would go, he would always go on stage and he was just like, great presenter, very eloquent, right? Kind of selling the vision. And of course, all the women would just be looking at him, wanting to speak to him.
Yeah, Roy had kind of a Steve Jobs kind of vibe.
Yeah, for sure.
And he was the tech guy. I mean, he oversaw all of the product and engineering side of the house. And then Ido was the salesman. Ido oversaw everything, go to market and everything around sales and marketing. Yeah.
Could you deep dive, like just, or what do you say? You say double click on this idea of the video visit, so what's your take after probably conducting that and building companies of that? What's really happening with the video visit versus some other type of?
Yeah. I mean, it's, prior to COVID, it was still a slow and up and coming idea. And then of course COVID hit and everyone said, well, gee, this is a no brainer, right? I can't get sick through the phone or through the internet. I'm not going to catch COVID showing up in an ER that's full of COVID patients. But, I think it's about efficiency. It's about meeting the patient where they are. I think video visits acknowledge that a touch exam is only necessary in certain circumstances. I mean, so much of healthcare is medication adjustment, discussing side effects, dealing with, mental health oriented challenges or other, behavior modification challenges. And so, telehealth is an efficient and convenient way to do a lot of these things. I mean, just look what's happened to telebehavioral health. It's really
Right.
In fact, I have a daughter who's a master's level therapist, and she's doing about 50% of her visits remotely these days. Just 'cause it's more convenient for the patient. They love it.
Yeah.
So
it's so interesting. Like Eugene and I, with the shot of digital health, this is a therapeutic intervention mostly. This is
for us, maybe not for the guest, but
but what I find is amazing is so 172 episodes, and when we meet people, actually my recall is very different than in-person meetings. So like if I met you in person, and I don't know if it's because I don't, because I can't see that, are you tall or are you this or the context of the room. But obviously it's much more intimate than if you were just exchanging emails. I would know.
Sure.
Like if we had a LinkedIn interaction or email interaction or a text. oh, maybe I remember, maybe you remember me, maybe you don't. The
I'm
video
sure, and even
better.
more so than remember the old phone bridges and the video, the phone conferencing. I mean, this is more intimate than that, right?
Yeah. But it doesn't quite, like, I'll all of a sudden, I'll see someone in just the context and I'll be like, oh shoot, yeah, we did hang out together, in that call. So there must be something happening that's completely different than an in-person, but, obviously better than a message.
But I think
That's right.
I think it's
when I
interesting.
liken it to work, work from home, I find that, it depends on the job, it depends on the person, how motivated they are. But, I find that I can be really efficient this way. I have 3 screens up right now. I have AI over here. I have my calendar over here and talking to you guys here. And I have a notepad here and I'm writing notes all the time. So there's an efficiency element, even for work from home. What I missed, though, from a work from home perspective, I missed the pop into somebody's office for a quick question, or the, taking one of a member of your team out to lunch, or, going out for a beer after work, that kind of stuff. I guess we haven't figured that one out yet in a work from home situation.
That's actually interesting, because I find, we're in Slack, and we'll sort of pop in, right? Like video, audio. It's not just Slack as in text, right? And
that seems the closest thing to a pop in, right? Yeah.
You do. I mean, we were kind of remote first company to begin with, don't have a physical office. So I think it's, you sort of adjust to it. But I was also going to comment. I mean, I agree. I mean, I think the video is there, and you build, like, especially in the day of, like, everything is AI. I think just actually seeing the face, even though I could be my digital twin AI right now, for all you guys know, but I think there's a time, a place. I think, for, let's say, Jim and I, this was a therapeutic intervention during COVID, because we're very, like, I'll say, extroverted, want to be out there. Many people just want to, call out. Like, we noticed in Your Coach, Our Business, like 30% of real-time synchronous sessions, people choose just to chat real time. The coach is available with them. So I think it just depends on you, to your point, Peter, your job, your circumstances. It's just,
I work with folks that are on the autistic spectrum, and, they're not so fond of the video visits generally. I mean, not everyone's different, of course. They'd rather, interact just asynchronously, which is usually fine, unless there's a really big issue you need to talk through.
Are they your investors?
Oh, sorry, Jim. Go ahead.
I said, no, are they your investors?
No.
No, I'm joking.
One of the most fundamental things you learn as a clinician is to recognize visually what's going on with a patient, right? I mean, I've had so many moments in my career where I walk into an exam room and I immediately know, this is not good. In the first second, you see this floppy child on the mom's lap that you immediately start to think about sepsis and meningitis and things like that. And, video adds that. And it doesn't have to be so extreme like this. I mean, it could just be somebody who's a little depressed and they're a little flat. It could be somebody who's manic and they're the opposite. There are things like that you can pick up on.
Awesome.
Just getting back to Amwell a little bit, because I know you spent quite a lot of time in there as part of your career, right? Like roughly
9 years,
decade. And I think anytime you're creating a category and there's this twist in technology, right? Like this unlock, right? And again, in 2006, it wasn't, right? 2020 was the big boost, but it was, and we've had Anne from ATA and others that are pushing kind of telemedicine codes, and she's fantastic. I think we've given her so many shout outs out of the 172 episodes. So, and we've had her on, but, I think there's, lobbying efforts, there's, it kind of makes sense logically, but maybe just in that decade, if you can talk through at least one or two kind of, oh shit moments, like, something that kind of as a team you've gathered and some lessons learned. I think, I haven't looked at Amwell stock
jump
lately.
Right out. So I was hired in and around the beginning of May of 2012. And now this was before the days where remote work was the pretty normal thing. And so I chose not to relocate my family. And so I flew out every Sunday from LA to Boston, stayed till Wednesday night, flew home, and then still saw patients on Thursday, Friday, and Saturday. So was a
No.
pretty hectic life for a while. But I was asked in May, we had a big, huge whale of a client that wanted an actual network for urgent care by telehealth for January 1st. And they wanted it in 50 states. We then had two other Amwell clients that jumped in on that and said we want it as well. And so I was asked to build that along with others, but I was the sole W-2 on day one that was tasked with building this. One of
So
the
you got
first things
50 state licenses yourself? No.
well, at one point I had 42.
Okay.
So I did get some of those, but as my operations head used to say, "You're the conductor. I don't need another violinist."
Right.
So she would rather me manage the clinicians rather than go do a few visits. But no, I one of the first things I did is I tried to understand the regulatory landscape, and it's complex. I mean, you have DEA, you have FDA, you have state by state regulations, especially as promulgated by the rules at the medical board level. And I went in and got a reference. I think it was from the CTEL, the Center for Telehealth and eHealth Law, if I'm not mistaken. And it listed what's known about all 50 states with regard to telehealth. And I could only find 7 out of the 50 states plus DC where it was clear that this was acceptable way to practice.
Wow.
And let's just say that was an oh shit moment. Sorry about the language. That was an how are we going to do this by 1/1 moment?
Right.
So I ran at that. I mean, we hired consultants. I went and met with over 20 medical boards that year. I mean, it was all hands on deck, because the last thing I wanted to do was put a physician at risk. I mean, we wanted to disrupt the marketplace. We wanted to innovate, create new models for care, but by no means did we want to break rules, regulations, or laws. And that was really important to me. So we gained clarity. There were a few states where clarity was a little murky. It was not quite clarity. It was translucency, but we got there. And I can say that after 9 years at Amwell, where I oversaw over 6 million visits, clinical visits of varying types, we never had a malpractice case come to us. We only had 2 clinicians who were ever really investigated by medical boards, and the investigations were frivolous. One was based on a pediatrician who didn't like that somebody else was seeing their patient. And the other one was about video versus audio, which both were resolved favorably. So never had a doctor get in trouble, never had a malpractice case. So I'm really proud of that.
Well done.
Amazing.
Yeah, fascinating. So many people would have run from that. Like, I feel like in medicine by nature, it's like, it feels like they're, it's like coming back to your football, you're playing offense versus defense. Most are defense.
Yeah. and listen, it's not easy in health tech. I think one of the things where maybe topics we're heading towards is, how do you ensure good clinical care in a health tech environment? And, there are headwinds. The business model itself, most of my experience in health tech, the business model is we want SaaS margins, but really what we're delivering is healthcare, and healthcare has much lower margins. And so how do you resolve that? Well, there are sometimes people in the business who will, I don't want to say cut corners. That's not fair. It's not cutting corners, but it's how do we develop a SaaS based valuation when we're providing healthcare, and so that's not easy, but it takes a strong clinical leader in an organization. I mean, you have to be there, and you have to have backbone, and you have to stand up to the forces that want to take the easy road, or do the easy thing, or not do as much quality assurance, or whatever the issue is. You have to be strong and forceful, and you have to sometimes use that clinical voice. I mean, I think twice as the owner of professional corporations, I had to go to leadership with my president of the PC hat on, and go to our legal counsel and say, I have a problem clinically right now. I'm not comfortable with what we're proposing we do here.
Yeah, got it.
And that's important. You got to be there for the patients and for the providers.
What do you think about this? Like during the course of this podcast, we'll have a note taker, right? That will kind of help us, publish the podcast really quickly. And I have this kind of like, 2 conflicting notions about that of like, if I was going to do a clinical visit and there was a note taker, which you kind of would think would be a good idea, but then also it's like my privacy and where's that going and how's that data? Like, and that's such in the fact that can run through AI now. Like, it can just be.
Yeah, I mean, this exists. Ambient note taking is a reality in healthcare already.
Yeah.
Yeah, it's a little bit challenging. You know, I think when I think about that, I think a little bit about how I felt when they started using fingerprints for for access on your cell phone.
Yeah.
I said, you know what? I only have one, the pointer finger on my right hand. So if and when that fingerprint, the data of that fingerprint gets out to the broader internet, what risk is that for me? You know, and so I think about it sort of like that. I mean, you know, HIPAA's a good enforcer of privacy. You know, it has teeth, as we know. But I would worry, I guess, most about what happens if if somebody breaks into a website and pulls these recordings. You know, what could be there?
I think with any technology, though, right? It's used for great and evil as well, right? Yeah. And I just actually literally this morning, a post came up that, the ambient AI for health systems and, physicians in the first 6 months of the year, almost $1 billion invested. I'm still kind of trying to understand the ultimate unit economics, the ARRs, and, is it a bubble, kind of the next bubble in this space for now. Yeah. Until things settle. As a patient, and let's presume that the trust, security, and privacy of all of this is there. I think it's fantastic because then I can actually talk to my doctor instead of them trying to take notes at the same time, right? And
we've all heard that, right? That I go to my doctor and they just stare at their computer screen the whole visit.
Yeah. Right. Yeah. Right. And actually, as a patient, I'd love to get. I loved. I'm gonna do a little shout out to Neko Health experience. I mean, I got a whole transcript of the conversation with the doc at the end, like blah, 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 right. This is what you have, and like it was fantastic. So I'm a fan. I don't know.
And, as one who's managed many clinicians over the years, thousands, the most inefficient part of a medical visit is the doctor writing their note. That is the thing that takes the most time. It's the least satisfying for the clinician, and for the patient if they're doing it while they're in the room. And so, I've always been interested in solutions like these. Now, 10 years ago, they weren't ready for prime time, or they weren't HIPAA compliant, or both. But now we're in a whole new world. Maybe it's the beginning of doctors getting back to actually making eye contact again. Wouldn't that be nice?
Right.
Yeah. That's a good one.
In fact,
I think
it's funny.
This is the quotable thing here.
Yeah, well, we've heard in feedback, when we get patient feedback on telehealth encounters, we've heard, I love telehealth. I mean, literally something like this. Summarizing, but I love telehealth because the doctor's actually looking at me again. Because here we are. I'm actually not even looking at you guys. I'm looking at my camera, but it feels like eye contact, right?
It feels like eye contact. Yeah, no, it's amazing. That's amazing. It's true. You don't have a choice. Like, did you read the Jamie Dimon, giving out to his staff? Did you read about that? The CEO of JP Morgan?
I think I read something that's pretty humorous, but yeah.
Yeah. Well, he got caught on video. He got caught on recording, probably purposely, kind of basically, blasting the staff, saying, don't show up on, put your camera on, be ready for the work, don't be texting and calling the guy an idiot, like while you're on the call. Kind of.
Well, there was a funny one. I thought it was him, but it might have been a different CEO who his advice to a group of people, or maybe it was at Microsoft. I shouldn't name the company because I don't remember exactly, but it was a CEO after a riff. His advice to those that were, and the riff, he was cited, one of the reasons cited for this reduction in force was increased efficiency due to AI. And his advice to those that were laid off was, use AI to find a new job. And I thought, that what irony there.
Yeah,
they're getting fired because of AI, and he tells them to use AI to find another job.
There's so much irony going on.
Yeah,
awesome. So so after Amwell,
lots of scars, I'm sure.
Well, yeah, and I think one last thing I would say about Amwell was it gave me the opportunity to go from a very early stage all the way through to a public offering.
Amazing.
And I stayed on for a little over a year after the IPO. So what an experience that was. And
I'm sure.
I will say the only bummer was I was in the group that would have been at the NYSE ringing the bell, but instead we had to do it Brady Bunch style on a Zoom Zoom call, which was missed
Yeah.
opportunity, but hey, it was a really useful experience in my career.
Because we've had two acquiree companies on, I think, right? Is that right? It was Silver Cloud or Silver Cloud?
Yeah, Silver Cloud. Oh, that's right. Did we have? I'm trying to remember if we had Ken on. But
yeah, we definitely. Oh, we didn't have Ken on.
maybe we
Okay.
didn't. Anyway, if we didn't, we should. I don't know what he's up to these days, but
But we had the other. Who else was it? Another guy. I can't. In my old man brain.
We made a few acquisitions over the years too, which was also an interesting experience, and learning about how to properly integrate and the do's and the don'ts. Let's say.
Right. It was all fast. It was all going fast.
Murray
Murray,
Brozinsky. That's it. That's it. I had to think about who else Amwell acquired and then track back to the shot. Yeah.
Yeah. Good. So shout out to Murray.
Yeah. So after that,
so we had 3 Amwell, or potentially 3. If
I love it. Love it. Yeah. After that experience and after the IPO, I'll be honest. Being in a public company wasn't as fun for me. No offense to anybody. Jim
knows it firsthand.
Yeah. All of a sudden, it's almost like there's a magnetic pull away from innovating towards, next quarterly earnings. Everything's about next quarterly earnings all of a sudden instead of innovation. At least that was my experience.
Sure.
So I went in, I took a stab at telebehavioral health. I went over to a company called Brightline. And Brightline was born right around the onset, right around March of, what was that year? 2020, I think.
It's Naomi, right? Naomi is ex-Livongo, so, work with Glenn.
They're based in Chicago.
Yeah, I think it's Chicago, and they went virtual, or no. Well, you tell us.
They were in the process of getting space to open a kind of a multidisciplinary behavioral health clinic for children in Palo Alto, and COVID hit, and they said, no, let's not sign that lease. And they transitioned to an electronic model, and that was a fun experience and a very mission oriented experience. Helping children with behavioral and mental health challenges is very fulfilling. And I at Brightline, their model is I think is a wonderful model. They have health coaches for the non-diagnostic problems, trouble with learning or studying habits, organizational skills, things like that.
Right.
They then have therapists for, your common mental health conditions like depression and anxiety, and then also psychiatrists. So when medications need to be considered and further evaluation. So it's a really nice model. Unfortunately, I think that the hardest thing for Brightline is that, if you're selling to employers, children's mental health is not in their top 5 or 6 point solutions that they're out shopping for.
Okay.
And so that was probably the hardest part, that it's a wonderful model, great outcomes, really good impact, but less people out shopping for that point solution. So they seem to be migrating back. I'm not in.
They snapped back. I mean, I saw, I met Naomi actually in Chicago ages ago, and we should have her on actually. Fascinating woman, and
she's wonderful.
Just the business. Yeah. But I think she wrote a big letter on LinkedIn, kind of, going back to the core, to the roots of what the model was supposed to be. So I know they've had some tough decisions to be made around people and everything else, but they seem to be
about. They're not really in the ABA, applied behavioral analysis business, but let's say if they were to extend, or if I just use this as an example, that's a model that's really, really hard to do electronically, right? If you have a moderate to severely autistic child, and you're helping them with behavior modification and behavior work, you really need to be in person, in my opinion. Although I do have a friend who has a startup in this area where they are trying to do some electronic work. But yeah, so if you use that as an example, you could just see the value of having a location that folks can go to where they can get really intensive type treatments and therapies.
Amazing.
Yeah, you even think about in therapy, in psychology, play therapy is a modality often used in the first decade of life just to build rapport and all that. Harder to do that electronically.
Right. Interesting. Yeah, no, that's.
Yeah, haven't thought about it that way, but it makes sense.
Yeah.
All right, and then
pros and cons. Little kids.
Yeah, listen, with everything else, Yeah, with
Yeah.
everything,
But
just like with everything.
I'm actually in Boston right now, and I was, just with my 85 and 86-year-old parents living in Boston, and and where there's all kinds of interesting things that they're very, very in tune and things going on, but they're also 86 and 85 years of age.
Right. It's true.
So there's a lot of, and you could see the game, like they're doing their crosswords in the morning, their little mini, that like all this, then they do their karaoke, and it's all this kind of playfulness and the rapport, and it's all about keeping the mental facilities and dealing with, where loneliness.
Loneliness is one of the great challenges in the
Absolutely.
elderly population, especially if they're on their own. If one has passed away.
Yeah.
It reminds me of an interesting phenomenon in the telehealth world. There was back in 2012, 2015, that era, the early days of telehealth on a regular PC. There was a lot of concern about lack of devices, especially in the elderly population, but also in higher poverty areas. There was also concerns about lack of internet access in certain areas of the country. But by and large, those problems seem to be going away. That it used to be like maybe above 60, above 65, maybe they're a little less used to using a smartphone or a tablet. It now seems like that age is maybe 85, 90. It's just they're so intuitive, so easy to use. I go visit my parents. My mother's hardly ever off her iPad. It's hard to get her attention.
Hello, like that. Screen ages.
But, I do want to expand. You brought up loneliness, right? And I know we're not in our kind of. What we find also just across our book of business that we think of loneliness. It's potentially a single aging adult, right? But what we're finding is people are lonely no matter what, right? To a certain extent, like no matter what age, right? Because some people don't want to talk to their bosses and the people on their team about certain things, but they're okay talking again, to a coach or somebody else, right, around it.
Right.
There are people that may not want to talk to their friends about certain things, and like loneliness just keeps coming up across different age groups. Actually,
isn't it ironic?
Fascinating.
This age of connectivity and social media, that people are probably, I don't have any data on this, but people are probably more lonely than they were 20 years ago.
100%. 100%.
Yeah.
I work out of these like WeWork offices, and I will go to different locations, and you'll see like the Boston. I live in Dublin, or I'll go visit Eugene and work out of a WeWork office in Barcelona, and the way that people interact with each other, and you can see that in Barcelona is phenomenal because they're kind of like it's eye contact, it's kind of smiles, it's kind of this community is social. Boston's a little austere. New York's a little more. Dublin's kind of in between. But you can see like a lot of people, because they work on their own, and even young people.
It sometimes takes a bad event to bring people together. You hear about New York after 9/11. Our smaller equivalent of that was these horrific fires we had in California last year. And
That's right.
I can't tell you how many times I spoke to people and they said, it is just so nice. People are coming together. They're talking to each other. They're helping each other.
Right.
It's just sad that doesn't happen unless or until there's a natural disaster,
like an Irish wake. Irish wake.
Yeah. So Brightline, fascinating company. And you moved to Lark then, or what's the?
Yeah, I did a little brief sojourn in between, trying out fractional roles and some consulting. I love to build. I love the early stages, and so as I was looking for my next role, I found that there were a number of companies that were looking for fractional CMOs. Especially early or stealth companies.
Right.
And a lot of people were looking for guidance on how to build a telework, which is old hat for me now. It's, I say I could do that in my sleep. And so I did some fraction work in women's health and pediatrics and all that for about a year, and enjoyed myself. I was also on a couple advisory boards, including one in the chatbot space. And so I was working a little bit more with them, helping them bridge the gap as a CMO left. But then, Eugene, to your point, then I ended up joining Lark, and kind of got a little bit more after Brightline and being in mental health. I was, coming back towards more medical care, and very exciting, and what attracted me to Brightline was that they, from the beginning, decided they were going to use technology to reinvent how care is delivered. In this case,
Lark, right?
Coaching care. Yeah, coaching care for chronic
Yep.
diseases. And they were using the old AI, machine learning.
Right.
I was gonna say I
And
looked it up, but we do a little bit of homework, right? And so
yeah,
Julia and Jeff started this in
that's right.
2011, so it's coming on to what 15 years next year, right?
Yeah,
It's
and keep
way
in
ahead
mind
of
the
their
first,
time.
let's say 7 or so years were primarily in the lab or
Yeah,
providing
R&D.
free coaching essentially to train their machine
Okay.
learning algorithms.
Yeah.
Yeah, yeah. And what's exciting about that is that it's still deterministic primarily. I will mention in a moment we do some work with LLMs carefully as well, but
Yeah.
it's still deterministic. So meaning it's evidence-based content or it's content written by our panel of experts. But then it's delivered in a more modern way. It's delivered in a text-like interface with videos and other content. And it's delivered in bite-sized chunks. Ideally, we want to interact with a member every day. And
Okay.
so it's very different than the notion of you see your primary care doctor, you're diagnosed with prediabetes or diabetes, and then they say, why don't you go make an appointment with a dietitian?
Right.
We find that dietitians are underutilized. There's also, they're not typically for one individual member or patient. They're not usually utilized for long term. When you have that visit, maybe you have a second visit to follow up on the diet recommendations, and then most members will drift away. So
Okay.
our idea is to keep with them and keep nudging them along on their path and their behavioral modification journey. And we think it's very effective.
Yeah.
It's interesting, right? Because I think part of it is, with every sort of evolution of a company, right? I think it's, and we've talked about this with many guests here, right? Access is key because access is so difficult, right? And depending on where you are in your life journey, your health journey, the neighborhood and the zip code you're in, your access is different. And so I think this mantra in a positive way of tools like Lark, right, or companies like Lark of access is absolutely there. But it's interesting, right, because you came in, and part of this is there still needs to be a human in the loop. I think we just saw either a Stanford or MIT study that just came out on AI therapy, and kind of how a real therapist is somewhere still needed in the loop, right? And you need to build the relationships. And so what I've seen, at least over the last, let's say, decade, was sort of going into this AI spike, right? But then back to communities, back to trust, back to humans.
Right.
So I'm curious kind of how you guys are looking at this at Lark, or your own opinion around it. Where's the line between, AI coach and chatbot and the human?
Yeah. It's a great question, and it's a tricky one to answer. I look for opportunities to achieve better results, right? And so, to give you an example, in our DPP program, we were able to get 40% of all enrollees to the 5% weight loss threshold that CDC recommends, and we're really proud of that. Age population, right? This is a population that no matter what the typical usual healthcare system tries to do, they really struggle to get these folks to follow the recommendations, to do what they need to do, and all of that. The way we approach it is as follows. We have a core of coaching, which we call the Lark Coach. And the Lark Coach is an automated AI, machine learning, organized set of deterministic content and assessments and education and all of these things that is available to the member every single day. We use techniques like positive psychology to try to motivate and help create baby steps. We create SMART goals towards their major goal, if their major goal is weight loss or reducing their A1C. So we have that as a baseline. We encourage everyone to use that as often as every day. We then layer on top of that the human components. And the way we do that is, first of all, live coaches bundled into the program, no cost to the member or to the employer, already bundled in. They can go anytime they want. So that rare patient that really wants that personal touch regularly, they can go in and have live coaching visits, and that works for them, and it works for us. And if it helps generate better outcomes, we're all in. We also have escalation points where we might nudge a patient towards a live coaching session. They're struggling with their diet, or they're in a weight loss program, but they're gaining, or they have
falling off, right?
and they're having side effects. Things like this. We have escalation points. we're now layering in the clinicians. And so that's part of why I came to Lark, was also to build the telehealth network. And in layering in the clinicians, first of all, important to mention, we don't want to disintermediate care with known, primary care docs or anything like that. We still want somebody to go to their doctor for their usual needs and their yearly physical and all those other recommended events. But what we can do when we bring in the clinicians that are integrated with the coaching is we can supersize our outcomes. Okay. We can adjust medications on the fly. We can provide access to care in 24 hours for a side effect on a GLP-1. We have protocols in place. We strongly believe that GLP-1s, when used for obesity, should be weaned after you get to goal. And so we have a whole weaning protocol that's both sensible, because who wants to be on this medication that makes you feel nauseated for the rest of your life? But it's also practical from a financial perspective. Who wants to pay $1,300 this price for a medication for the next 20 years just to maintain the weight that was lost? It's just not practical.
Yeah.
So that's how we approach this. Our physicians then can also coordinate care with known providers. They can prescribe, they can order labs. So we increase our data. We now have labs, we have diagnoses, we have medication reconciliation done by a human being. And so
you're doing a lot of
all together, we think that really provides value.
Are you publishing a lot of the evidence that you're seeing?
Yeah, we've published 22 articles in peer-reviewed journals.
Okay.
Most of our, I'll be totally transparent. Most of what we published is retrospective. We haven't put a lot of effort into prospective studies, although we are planning one for our GLP-1 work. And I will share, I have some preliminary data. Out in the community, you hear stories about persistence on GLP-1 medications being very low. As many as 50% will drop off in the first month. And there's studies that show by 1 year on GLP-1s for obesity, 37 to 42% of members are still taking them. We're 7 months in to a major GLP-1 support program with a major PBM. And 7 months in, we're at 80% persistence on GLP-1.
Wow. Amazing.
So we're proud of that. We think this is an early signal, and we're looking to.
And you can help people fight through the natural issues that come up with having to inject yourself.
The gut health and all that.
And we have had one aid from the broader community that's not our responsibility, which is the shortages are by and large resolved. That was a way on persistence as well, a weight on persistence. But even given that, we're still well ahead of what we're seeing in
That's amazing results
in published journals. Yeah.
Well, it's crazy how fast.
Listen, if you're going to take this expensive medication, sorry to interrupt you, Eugene.
Yeah.
If you're going to take this expensive medication, you might as well use it properly, right? And keep using
for sure.
You're not going to get results if you stop it.
And actually, for the employers who are, either, contributing, paying some of it, all of it, whatever the mix is, right? I mean, you don't want to spend, $1,500 for 2 months in a row, and then people drop off without any.
And you also don't want to continue paying for it when it's not working. There's that small percentage that won't lose weight on a GLP-1. Why would you keep paying the money for this medication? Right.
100%.
Yeah. Our proposition with employers, just real quick, one thing. Maybe
please.
Ready to wrap up, but our proposition to employers is we can help you achieve meaningful clinical results, but also some semblance of financial results. That's really our goal. We take a population health approach. There's only so much money to spend. Let's spend it wisely.
Right.
Yep.
Right.
Yeah.
Time goes by quickly, so we're gonna and especially when fascinating guests are on. So I'm gonna pass it to Jim for the last question, and we'll wrap it up.
Right. Wonderful. Okay. So Peter, stay with us here for a second. So we're gonna go blast into the future, and we're about 3 years in the future, and some beautiful studies have been published by Lark around the effects of your model, nudging people towards better healthcare outcomes, and your capacity to use ambient note taking, and people are fascinated by the work and the growth and the medical impact they're having. So Aaron from ATA invites you to keynote the conference and to describe how you've done this. So you're up giving this talk, and people they're diligently giving you eye contact and ambiently note taking from the audience as they're looking at you. And you see one, and this handsome man is sitting in the front of the audience, and he looks like he's maybe just out of medical school, and he just is staring at you, and you're like, Jesus, what, that kid's really fascinated by my lecture, and he comes off, he beelines right to you, and he walks in and he says, Peter, you don't understand. I'm about to become a CMO and co-founder to a med tech startup that's looking to, bring modern health services across the country. And I've been following you, and I'm a failed Browns fan. I met my now wife in gross anatomy class. I'm an offensive, I play forward in my pickup football team. And, I've studied this, and I've been following your career, and you're looking at that young technology there in eases. I also, like you, I have 42 licenses across all these states right now, and I'm looking to get my 43rd license. But you look at that young version of yourself as he's about to start in his career. What's the one piece of advice you would give him?
Think big. Think big. I'll even add to the answer. The first book I would give him is something by Clayton Christensen about disruptive innovation.
Awesome.
And say, you're welcome to do incremental innovation if you want, but my suggestion is disrupt
Amazing.
And think big.
Love it. Very simple 2 words, but they mean a lot. Peter, thank you for joining us this morning.
My pleasure.
And
Thanks for inviting me.
For our guests and listeners, hit subscribe, pass it on, and we may or may not see you next week. Let's see.
Thanks, Peter. That's great.
Thanks, guys.
Take care.